web ما ادري شو اسمه program. So let's start with a case. So we have a patient. His name is JM. He's a 38 years old male who is national from UAE. He presented to the internal medicine clinic because of chest pain. The chest pain has been going with for 6 months now. He describes the chest pain as food getting stuck in his mid chest. Okay, and the food. This symptoms started with large amount of foods first, then it's getting worse, and now any size food he swallows, he feels it's getting stuck in the mid chest. So he keeps on drinking water to relieve this pain or this uncomfort feeling. Uncomfort feeling. So the patient can drink water or liquids without issue. He does not choke when he swallows food. He can initiate swallowing. He doesn't have any pain while swallowing, and he only gets that blockage of the chest or this discomfort. The patient denies any regurgitation or food getting back to his throat, and he denies excessive salivation. He doesn't have much of salivation. So what other questions you would like to ask?
Is this getting worse?
Is this getting worse?
Yeah, it is getting worse. As I told you, it's progressive. It started with large boluses of food. Now it's any solid food he takes.
What about liquids? He doesn't have any issue throughout the 6 months.
What do you mean by any issue?
Like, does he have difficulty swallowing liquids?
No, he doesn't. It's only solids. Okay, so the patient didn't have any episodes. So now let's go back to so what is the chief complaint of this patient?
So the chief complaint is difficulty in swallowing food for 6 months.
For 6 months.
Okay, so what do you call that in a medical term?
Dysphagia.
Okay. So he has dysphagia. So whenever you take history from a patient, try to think of the differentials of that chief complaint and you ask about them. So you told me that it's progressive. So what other things that can cause dysphagia?
Dr. Abdul.
Yes.
I think the sounds echo because you don't have microphone.
Oh, just wait.
So it'll be better if you can. Your mic on.
Because
your mic on.
Either he can use microphone or not use.
Now, is it better?
No. I can still hear myself.
I'm sorry because I try to connect my AirPods and I don't know how.
Mr. Arfan, how can you make it better?
The only thing which now other person can't eat.
Okay. Can I leave the meeting and come back? Can we try this?
Sure.
Okay.
So Rhoda, we can also check if we speak, is there echo? I don't think so that there is echo when we speak, right?
Hello?
Yes, doctor. Welcome back.
Now it's better, right?
Yes.
Okay.
Yes.
Okay.
Yes.
So let me tell you more about the let me tell you more about the history of present illness. So this patient, he doesn't have any history of recurrent infections or any history of recurrent diarrhea. So why do you think that's important to ask about?
Doctor, before you go ahead, can I have one question? Is the dysphagia more upper or in his lower areas, like
So
more
what do you
near his
think?
throat or more lower?
He said it's in the middle chest. He feel food stuck in the middle chest.
Mhm.
So what do you think? You think it's an upper esophageal problem, or it's in the middle esophageal problem?
middle esophageal.
More likely middle.
In the middle. Okay. So okay. What's okay? How do you define? Okay. How do you differentiate dysphagia? So dysphagia can be oropharyngeal, or it can be esophageal. So it can be in the upper part of the esophagus, and it could be in the esophagus itself. So the oropharyngeal dysphagia. So the patient, what the patient would have in
He
an
will
oral
have difficulty
oral.
with initiating the swallowing.
Yes, exactly. So the problem will the patient will tell you that I have a problem in initiating swallowing, and what else that usually or most probably accompanies dysphagia in those cases.
Choking.
Choking, no, other things. Choking
Aspiration
definitely can be there.
or
Okay, what I'm
regurgitation.
looking for is odinophagia. So the patient can most probably have pain while swallowing because he cannot swallow. So he gets a stretching of the pharynx and the upper esophagus. He would have pain during the swallowing. Okay, so that's what usually accompanies dysphagia in those cases. So oropharyngeal dysphagia, for a patient who cannot initiate swallowing, and look for a patient who has pain with swallowing. So those two can guide you toward oropharyngeal dysphagia. So what other things you would think of? So this patient does not have oropharyngeal dysphagia. So this patient has esophageal dysphagia. So the problem is in the esophagus. So think of things that you need to ask in any patient who has a problem with the esophagus. Okay, so one of the things that can cause esophageal dysphagia is what? Is GERD structures. So you need to ask about the history of GERD, صح?
Yes.
Yes.
So in this patient, he does have a history of GERD. He has a history of acid reflux for 2 years, and he has been taking antacids for it and PPIs. He get them from the pharmacy. He didn't follow up, or he never had any endoscopy for this. Okay, so that's one thing you need to ask. What other things you need to ask? Things that
Did
can
it
cause
improve,
esophageal
doctor,
dysmorphia.
on the PPI?
Improve with what?
With the PPI,
The reflux does improve, but the stage is something new.
This page is something new.
Yeah.
Okay. Does he have any weight loss symptoms? Any?
Yes, exactly. So he does have weight loss. He weighs now 103 kilograms, and he weighted before a few months 112 kilograms. Okay.
And was
So
this
that's
weight loss intentional?
no, it was not intentional.
Mhm.
So basically, any patients with dysphagia will have weight loss because you can't go get food in, so you have low calorie intake, so you would have weight loss. But weight loss can guide you if you have a severe weight loss or a huge amount of weight loss. You might think it's because of cancer, for example. Okay, but you need to ask about. You definitely need to ask about weight loss. What other things you need to ask? Constitutional symptoms. You need to ask about fever. He does not have fever, and he does not have night sweats.
Doctor, what about recent change in the bowel habits?
Yeah, that's important. Any patient presenting with any GI complaint, you need to ask about constipation and diarrhea. The patient does not have constipation, does not have diarrhea. He opens his bowels in a normal amount, normal 3 times per day, normal amount, normal consistency of stools.
Doctor, is there any hematemesis?
No, that's another thing which is important you need to ask, but he does not have any hematemesis. And he does not have any episodes where he got like this sudden, the dysphagia is not sudden. It is not associated with the sudden onset of chest pain. The dysphagia also, the patient does not remember having any episodes of bluish discoloration of the fingers. Why did I mention that?
Maybe scleroderma, doctor, you're thinking about?
Exactly. Scleroderma can cause dysphagia. Okay. So,
doctor, did he have any black stools?
No, that's very important. Thank you for mentioning that. Why you ask about black stools?
Maybe he's not having hematemesis, but upper GI bleeding can cause black stools.
Yeah, so basically, if you have a problem, for example, let's say a peptic ulcer disease. Peptic ulcer disease can give you long-standing GERD and give you melena. So that will, if the patient does have melena, then that would tell you that the patient really might have something with the stomach, or he might have a bleeding lesion from the esophagus. So it will tell you, it will guide you toward the diagnosis. So he does not have any melena. So let's move on to the allergies and family. So he does not have any allergies. Family history is he is married. He has 3 kids. He has 1 child of cerebral palsy, but otherwise he has no any other medical issue running in his family. Social history. So that's the social history. So he does smoke. He smokes a lot, around 2 to 3 packs per day for 20 years. He does not drink alcohol. Okay, so what other things you want to know? Anything missing? Anything you think you want to know about in the history?
So doctor, we said he has no choking sensation, right, doctor?
No, he does not have any choking sensation. He does not have any regurgitation. So
does he have any recent vomiting?
No, he did not vomit.
Okay.
So let's go to the vitals. He is vitally stable. So he is afebrile, vitally stable. So vitals are normal. In physical examination, so what things you would look for in the physical examination? So you have this patient, he's standing or he's sitting. So what things you would start with?
I will start with general inspection for him. Is he in distress or is he fatigued? Is
Okay,
he
so ask
pale
me. So
or
I am the patient. So ask me and I'll tell you. So I am not in distress. You can know that from the vitals. Okay, I am not in distress. What else you would look for in the physical exam? In the general physical examination. So I'm comfortable. I'm not in distress. What other things?
Do you have any current pain? Any pain in your chest?
No. He does not have any pain. No.
Okay.
So what do you do in general exam? You only see distress in this general exam?
We can see if he's sitting comfortably. Maybe he's sitting in some position that makes his pain easier.
No, he can sit in any position. He can lay down. He can sit like upright. He can stand. He doesn't have any problem with position change. So things you do in general exam. Remember Jakun?
Yes.
you need to look for jaundice. You need to look for anemia, clubbing. What else? Cyanosis,
Edema.
lymphadenopathy,
Edema.
and edema.
Yes.
Yeah. So he does not have jaundice. He is not pallor. He does not have any edema. He does not have lymphadenopathy. Why lymphadenopathy particularly important in this case?
Suspecting GI cancer or infiltration.
Exactly. So what do you see in GI cancer? Which lymph node will be enlarged?
The supraclavicular.
Which one?
Left one.
Left. What do you call that?
Virtue.
Workhouse, yeah.
Exactly.
Virgo, yeah.
Exactly.
Yeah.
Exactly. صح. So this patient does not have lymphadenopathy. So that's the general examination. One more thing I'll tell you to do in any patient who's when you do general examination. We haven't been taught this, but this will help you a lot. Look for hygiene and smell the patient. So if a patient presented, for example, that has nothing to do with the case, with epigastric pain, and we went close to him and you smell alcohol, so that can tell you that this patient might have an alcoholic intoxication. In this case, if a patient has dysphagia and you get close to him and you really smelled something really bad from his mouth, so what do you call that? You call that halitosis.
Halitosis, yeah.
Yes, that can direct you toward which diagnosis? Which?
Zenker's diverticulum.
Exactly, صح. Zenker's diverticulum. Typical USMLE exam question. An old patient presented with regurgitation, choking, and halitosis. It's a really bad smelling disease because you have food stuck in the Zenker diverticulum, which get undigested. If you have a lot of food left in your room, you smell it will still smell bad with time.
Mm-hmm.
So this patient does not have any halitosis. And of course, don't ask patients, do you smell bad or la? Because they will leave you. Okay. So now let's go to the cardiovascular examination. So basically, this patient has normal cardiovascular exam, including there were no murmurs in examination. Why do I look specifically for murmurs in patients with dysphagia? That's a really little difficult question, but
Doctor, could be left atrial enlargement can cause dysphagia?
MashaAllah. Hamid, your name?
Yes.
صح, Hamid. You're absolutely right. Patients with left atrial enlargement, because remember the anatomy, the left atrium is directly anterior to the esophagus. So patients with left atrial enlargement, they get dysphagia. So which murmur, which valve abnormality give you left atrial enlargement? So mitral stenosis can give you left atrial enlargement. So mitral valve pathology, even mitral regurg in severe form, can give you left atrium enlargement. So that's absolutely right. So that's the physical examination and the cardiovascular examination. Respiratory examination, there is nothing really related to dysphagia during resp exam, but you do it to check for any congestion, any signs of effusion. So if this patient, you suspect cancer and you think and you saw that this patient is congested or he might have a signs of effusion, then you think that maybe a metastatic cancer. But otherwise, there is nothing related to dysphagia that I can think of. Now, of course, you're gonna do GI exam. So what things you look for in the GI examination?
So first we begin, doctor, with inspection.
Yeah.
We might think if there's signs of liver disease like spider angiomata, or if there's a distended abdomen, maybe ascites can cause.
Yeah.
Want to see if there's any visible palpations.
Yeah, and what things that are related to dysphagia you think might the patient have in GI exam that will help you defining the types of dysphagia? So basically, if the patient has epigastric tenderness,
Mm-hmm.
so epigastric tenderness, it's related to peptic ulcer disease. So if a patient has epigastric tenderness and he's having dysphagia, so that would tell you again that this patient might have a peptic ulcer disease because of his resulting in dysphagia. Okay. So that's also important in the GI exam. So with this patient, the GI examination was absolutely normal.
Mm-hmm.
Yeah. So other things you would look in the you will do in the GI exam, not necessarily every patient, but you would certainly think if you suspect Crohn disease in a patient, then you would definitely look for them. Anal fistula. So you need to look for you need to visualize the anal canal, and you look for anal fistulas that are related to Crohn disease. What neurological? So why do you do a neurological exam in dysphagia? Do you know why?
Doctor, before we move on,
Yeah.
from Crohn's disease, you said, can it cause dysphagia, doctor? Crohn's disease?
Yes, Crohn disease, mouth to anus. It can cause anything through that tract. So it can cause dysphagia. It can cause bowel obstruction. It can cause diarrhea. Crohn disease can present in any way in the GI tract.
Okay.
In opposed to ulcerative colitis, where it's only located in the colon. Okay. So Crohn disease, I don't say that it's common. It's rare, but it's there. It's one of the differentials. So let's move on to the neurological examination. Usually in every patient with dysphagia, you do neurological exam. Why?
Can be like he has a neurological problem, so he cannot swallow.
That exactly. If a patient has a stroke and he didn't swallow because of the stroke, so that's a sign. This can tell. This might be the reason for dysphagia. Other things, MS, transverse myelitis, amyotrophic lateral sclerosis. Exactly. So all of this can cause dysphagia. Okay. Usually, which type? Oropharyngeal dysphagia, not esophageal, because remember the esophagus, the first third of the esophagus is skeletal muscles. The other portion of the esophagus is a smooth muscle. So if you have a skeletal muscle abnormality like a stroke, AMS, multiple sclerosis, you get more of oropharyngeal dysphagia. So that's the neurological examination. One thing that I forgot to mention in general examination in patients with dysphagia, you need to look for things related to scleroderma. So what things you need to look for in a patient with suspected scleroderma-induced dysphagia? So what signs you will see in patients with scleroderma?
So, doctor, like you said in the beginning, that we will have skin changes. And
what skin changes?
Like you can see the Raynaud's phenomena.
That's one. What else?
Tight skin. Tight skin, yeah.
Yeah. The other things you need to look for are telangiectasias and spider-like fingers, scilodactyly. So you have that famous Crest syndrome. So do you know Crest syndrome? Crest syndrome, calcinosis. What is the R?
Raynaud's phenomenon.
E.
Esophageal dysfunction.
Exactly. This is the cause. This is the dysphagia. Okay. What is the S?
Sclerodactyly.
صح. And the T? Telangiectasias. Okay, so that's the famous Crest syndrome. What antibody you look for in Crest syndrome? That's a typical exam question.
Centromere.
Anticentromere and anticentromere. Crest starts with C. The antibody starts with C, anticentromere. While in scleroderma, in general, you do anti-topoisomerase 1 or scleroderma 70 antibodies. Okay, let's move on. So this patient, neurological examination was absolutely fine. He did not have any weakness. He did not have any hoarseness. He did not have any problems with the oral with the palate or with the gag reflex. So that the cranial nerve and the neurological examination was normal. Let's move to the investigation. So now this patient has dysphagia. So what things you would order for this patient? And please start with things that are simple.
So, doctor, we can start with a CBC, a general CBC.
Why?
See, we can see if there's any anemia, like we said, maybe anemia in the patient,
Okay.
if he's having any blood loss or like any occult bleeding.
So anemia also can tell you that it's a chronic issue, because if you have a chronic anemia of chronic disease can present with patients with Crohn, can present patients with scleroderma. Anemia also can present with cancer. So please look for anemia. Exactly. I agree. What other things you would look in the CBC?
If there's any inflammatory process going on.
Yeah. WB count can help you. Okay. What WB count, if it's elevated and the patient has dysphagia, then that tell you that this patient might have esophagitis. Okay, so this is one of the differentials for dysphagia. What other things you would order? So you said CBC. What other things?
Doctor, could it be maybe the blood or WBC is very low, and could be his esophagitis, could be because of he has AIDS or some other disease.
صح. Exactly. And esophagitis. So we will get back to esophagitis. So basically now, I think let's finish the case first, then we go to define dysphagia and its causes. I'll give you a very simple way to know what's the cause. So esophagitis, exactly, HIV or infections related esophagitis, they can get low WB count, exactly, in patients who are immunocompromised. So that's related to CBC. U and E, you would do them. Why? Because you need to look at the sodium, to the potassium level, it's not really specific, but you do them anyway, because you're gonna prick the patient. You take the electrolytes as well, and it can help you in regards to treatment. And it's not just more of a general test. What now? Let's go to specific tests, specific things you would do for this patient with dysphagia. So what's the first invasive test you would do?
The barium swallow.
Okay, so barium swallow, that's a traditional way to do this, to do it in dysphagia. Now it's still done. I'm not saying it's not done, but barium swallow, it can view the esophagus, but you still need to do endoscopy as well, because if you saw a structure, you need to do endoscopy and visualize the structure. So many people, they start with EGD. They start with the endoscopy, they start with endoscopy. So barium swallow, I agree, but the first initial step in all the guidelines says EGD. But it's a controversial whether to start barium swallow before the EGD or after the EGD. To be safe, just answer EGD. Okay, so you do EGD and biopsy. What EGD can help you, or what is EGD? It's esophageal gastroduodenoscopy. Or endoscopy, upper endoscopy. Upper endoscopy can help you visualizing the lesion. So if you went to the esophagus and you saw a really bad fungating mass, ugly mass, that can tell you that this is probably a cancer. If you saw a symmetric structure, so that's maybe a structure caused by GERD. If you saw, for example, so specific lesions, they have specific features in endoscopy. You don't have to know them, but it can help you. You can see, for example, rings and whips in endoscopy. So those things can help you. The second benefit of endoscopy is endoscopy can allow you to take biopsy, because remember, many of those causes of dysphagia, you need a pathological diagnosis. You need to take a biopsy and wait for the pathology report. The third thing that benefits you when you do an endoscopy, it can be a therapeutic. You can do therapeutic measures. So, for example, it skids his ring. So when you insert endoscopy and you see a Skidsi's ring in the lower esophageal sphincter, you can lyse the ring, and the patient gets cured from his dysphagia. So it can be a therapeutic, diagnostic method. Okay, barium swallow, it can help you with diagnosis. It can help you visualizing the esophagus, but even if you saw the esophagus, you need to do an endoscopy afterwards. Okay, so barium swallow is a good choice, but you need to do an endoscopy as well. What's the third test that you want to necessarily do in this patient, but you would do in patients with suspected motility disorders of the esophagus?
The manometry.
The manometry, exactly. So let's talk about this patient, and then we will go through each differential of dysphagia. So this patient had an endoscopy, had the labs were normal, the CBC and the electrolytes. He had an endoscopy, and the endoscopy showed a fungating mass. Okay, it's an asymmetric, fungating, ugly-looking mass. Biopsy were taken, and he was diagnosed with squamous cell carcinoma of the esophagus. CT, chest, abdomen, pelvis was done to see if there are any further metastases, and the patient was referred to oncology service for further treatment. Now, let's talk about esophageal cancers. The diagnosis is esophageal cancer. So esophageal cancer can be two types usually: adenocarcinoma and squamous cell carcinoma. So which one? So which one is more common with GERD?
Adenocarcinoma?
Yeah. So usually, where is the location for adenocarcinoma?
It's the lower 1/3, doctor.
Exactly. What about the squamous cell carcinoma?
The upper 2/3?
Exactly. So this patient has a squamous cell carcinoma, probably because of smoking. He's very heavy smoker, but even he has risk factor for adenocarcinoma as well. So he had the biopsy, and whenever you see a cancer or whenever you diagnose a cancer, you do staging. So you do CT, full body CT, chest, abdomen, pelvis, to see if there are any mets, and then you stage the lesion and you treat it accordingly. Treatment for cancers is not for you, is not for me. It's only for the oncologist. Okay, so we don't know what's the treatment unless we stage, and it's really patient dependent for patient specific treatment. Now let's go over dysphagia in general. So dysphagia, dysphagia has two arms. Okay, so it's two categories. It's either oropharyngeal or it's esophageal. So let's go to the oropharyngeal causes of dysphagia. You can divide them into structural causes or neuromuscular causes. So what are the structural causes of oropharyngeal dysphagia?
Maybe, doctor, there's an anatomical injury.
Yeah.
Or
So
something in the mouth.
think of something anatomical, something structural problem. So what's anatomical injury? What do you mean by anatomical injury?
So, doctor, maybe if the patient has an accident or something that caused his jaw or his mantle to be disfigured.
Okay, so we can say that's one of the things that can cause oropharyngeal dysphagia. So maybe trauma can cause
Yes.
oropharyngeal structural abnormality to the oropharynx, which can cause dysphagia. What other things that can cause things that are like more testable in the exams? Zenker diverticulum, you said?
Yes.
For
Doctor,
foreign
that's
body.
upper?
Cancers. Yeah, exactly. Thank you for mentioning that. Foreign body or acute food obstruction or acute food impaction That's the most common cause for acute dysphagia. Okay, but usually those patients like vomit and then it gets relieved. Other things that you can have cervical whips, but that's rare. But you have them that can cause oropharyngeal dysphagia. So that's the structural causes. What about the most common cause of oropharyngeal dysphagia? Neuromuscular causes. So we said stroke, MS, and everything. That's the reason in any patient with stroke, you offer them speech therapy, because speech therapy, they will assist the swallowing capability of the patient. We call it as commonly known SLP assessment. So SLP will see if this patient can swallow or not. And any patient who is bedbound, any patient who's have dementia patients with strokes, you do that because you want to know if they can swallow or not. If they can't swallow, then you go to other modes of feeding, such as NG tube or a PEC tube or feeding tube. Okay, but that's another topic. So that's usually the causes of oropharyngeal dysphagia. How do you differentiate oropharyngeal from esophageal dysphagia? We said that oropharyngeal usually they come with regurgitation, they come with choking, they have difficulty initiating swallowing, while dysphagia is more of food stucking in the chest. So the clavicle is your beginning point. So your takeoff point. If you have something abnormality above the clavicle, that's oropharyngeal. Below the clavicle, it's esophageal. Now let's go to the esophageal really quick. So we have structural causes of esophageal dysphagia, and you have functional causes of esophageal dysphagia. So what are the functional causes? So there is nothing obstructing the esophagus. It's mainly motility disorder of the esophagus. So how do you differentiate the two?
Achalasia.
Before going to the differential, how do you differentiate it's structural or functional or motility disorder?
Doctor, you mean by test or by examination or history?
By history.
So if there's a structural, doctor, I think it will be immediate, the cause, but maybe motility can be in spasm or like episodes.
Okay, so motility can be episodes. The structure, it's okay. Both of them can be episodes in some cases, but mostly structures are progressive. The functional are not. Structural, they begin with solid, then liquid, and functional, they begin with solid and liquid at the same time. Okay, so that's the way to differentiate. So functional esophageal dysphagia, you have three diagnoses, three things that can cause functional esophageal dysphagia. So rule them out, and everything else is structural. So what are the functional causes of esophageal dysphagia? You said achalasia. So what is achalasia?
It's the loss of inhibitory motor neurons in the lower 1/3, which causes dysphagia, basically, in the patient. And you will see the bird beak on barium swallow.
Exactly. So achalasia is a problem of relaxation of the lower esophageal sphincter. So the lower esophageal sphincter cannot relax. The food will get stuck. And that would show you a bird's beak in the barium swallow. That's pathognomonic for achalasia. But again, when you see achalasia, you need to do what? You need to do endoscopy. Why? Because you need to have a pathological diagnosis of achalasia. It could be cancer presenting like achalasia. You don't know unless you biopsy the lesion. What things you would see in manometry in achalasia?
There will always be a high pressure in the lower area, doctor?
Yeah, so in manometry, you will see always there is a contraction in the lower esophageal sphincter. So that's achalasia. The opposite of achalasia is scleroderma. So what's the problem in scleroderma? How does scleroderma cause dysphagia? So basically, scleroderma replaces all the muscles in the lower esophageal sphincter with what? With collagen.
Fibrosis?
Yeah, basically. So the patient will not be able, the lower esophageal sphincter will not be able to contract. So the patient will have long-standing GERD and dysphagia because there's no propulsive movement leading the food from the esophagus toward the stomach. So what you see in the manometry, barium solid, there's nothing specific. In manometry, what you would see is there is no contraction in the lower esophageal sphincter. So treatment for achalasia, let's go back. Treatment for achalasia, you resect that part of the sphincter. So when you resect it, what the patient might have as a complication is long-standing GERD because the patient has no lower esophageal sphincter. So that's what you see in scleroderma, because when you don't have a lower esophageal sphincter, you have a long-standing GERD. So in patients with scleroderma, you control the scleroderma and you give them PPIs. That's it. Nothing else, unfortunately. In patients, the last differential is this diffuse esophageal spasm. So how do patients with diffuse esophageal spasm present?
So, doctor, they can have chest pains, and which can be episodic.
Yeah.
And sometimes, I'm not sure about this, but they can be relieved by calcium channel blockers.
Yeah, that's exactly right. That's exactly right. So this patient presented with sudden onset of crushing chest pain with diaphoresis. He thinks he's gonna die. He came to the ER. ECG was normal. You need to rule out what MI, because when that patient presents with chest pain, he will be given nitrates and he will get relieved by his pain. So you need to rule out MI in those patients. Okay. If a patient presented with crushing chest pain and you told me that the most common differential is diffuse esophageal spasm, then you are not a safe physician. The most important thing is to rule out MI. So those patients usually they get dysphagia of solid and liquids together, sudden episodic, relieved by nitrates and calcium channel blockers. So what things that you would see in manometry and in barium swallow? So that's the most pathognomonic things that you would see. So in barium swallow, what do you see?
I think it would be normal, doctor.
No, in barium swallow, during the episode, you get what's so-called corkscrew esophagus. So corkscrew esophagus. That's what you have in patients with diffuse esophageal spasm. Or another name is nutcracker esophagus as well. It's the same thing. And in the manometry, you get areas with high contractility and areas of the esophagus that are not contractile. So you have like a string in like strings in the manometry. You see area of contraction, area not contraction, area of contraction, area of non-contraction. So that's specific for diffuse esophageal spasm. So it's not an emergency. The treatment, like when you diagnose it, it's not an emergency. So the treatment is calcium channel blockers and nitrates. That's Let's go more of the structural causes of esophageal esophageal dysphagia. We said cancer. You treat them. You send them to oncology, and then they get treated. You have a structure related to GERD, and you don't really diagnose. You don't really differentiate between cancer and structure from the history. Both of them they present the same way. You need to do an endoscopy to differentiate. In patients with structures, you might dilate the structure and you give them PPIs. That's it. Other causes of structural abnormality, we have webs and rings and webs. So we have something called Kinsey's ring. So we call that also. It has another funny name. Remember that Stakehouse dysphagia. So this is a patient who usually has no problem with swallowing food, but then when he goes to party and he goes to the steakhouse and he eats a large portion of food or large boluses of food, he feels food getting stuck because the lower part of the esophagus is narrowed by a ring. So that's Kinsey's ring. So what you do endoscopy, and then you lyse the ring, and the patient gets relieved. The other thing, you have something called WIPS. Something called the Plumer-Vinson syndrome, which is a patient who
Iron
is
deficiency.
yeah, exactly, iron deficiency anemia with dysphagia, and usually it's a woman. So you treat them with iron supplements. You do regular endoscopies to make sure that they don't have cancer, because they have higher chance of having cancer. Other things that can cause esophageal dysphagia or structural esophageal dysphagia is compression from other from surrounding structures. So remember, patients with mitral stenosis, left atrial heart enlargement, patient with mediastinal masses, they can present that way. But you usually rule them out after you ruled out structural causes, after an EGD, after the diagnostic evaluation for this dysphagia. If you think that the patient he might have something else, you do CT, for example, to see other things. The last thing, I'm sorry, I'm going fast because of the time. The last thing that is very tested in the exam is esophagitis. So look for a patient with esophageal dysphagia. So patient with food getting stuck and pain. They get problems with swallowing and food getting stuck. So let me rephrase that. A patient has painful swallowing with food getting stuck in the chest. So those two things go with esophagitis. And what are the causes for esophagitis?
Could be infectious or non-infectious, doctor.
So, okay. So let me. So it's an infect. So three things. There are 5 causes. First of all, infectious. Second thing is pill esophagitis. Third thing is eosinophilic esophagitis. The fourth thing is GERD. And the last thing is caustic, so something burning or something that burn the esophagus. So infectious, think 4 things that can cause. There are many causes for infectious esophagitis, but I want you to remember 4 things: Candida, herpes simplex, HIV, and CMV. So in Candida, patient present with dysphagia, painful swallowing, and you open their mouth and you see oral thrush. That's candidiasis. You see oral thrush. HSV, you see herpes simplex lesions which are ulcerative vasovesicular lesions that are with different healing different healing stages. So that's herpes simplex. Patients with opportunistic infections. So if you did endoscopy, you definitely do endoscopy for all of those. Okay, so if you did an endoscopy and you saw that you cultured an organism that is really opportunistic, then you think of HIV, for example, fungal infections and other things. So you think of HIV and you start them on treatment. CMV, usually there is no test to do it, but put them in mind. You can order them in patients who are immunocompromised. You order the level. There is nothing in the physical that will guide you. The other thing is pill esophagitis, which is the patient is taking a pill which can cause esophagitis. The most common pill is what? The exams, we learn them a lot. Something to do with bone, with calcium, with phosphate. Which class of medications?
Bisphosphonates?
Exactly. Bisphosphonates, they can cause esophagitis. Tetracyclines, they can get esophagitis. So pill esophagitis. So think of medications. The other thing is eosinophilic esophagitis. That's a very common increasing entity in the United States, and many it's a very good field for research right now. So eosinophilic esophagitis. So as the name implies, it's eosinophilia related esophagitis. So you think of things that can give you eosinophilia. So what things that can give you eosinophilia? Asthma, atopy, allergy. So those patients have some sort of allergic condition. In those patients, when you do endoscopy and you do the biopsy and the biopsy reveals eosinophilia, you need to ask yourself one question. Is the patient has GERD or was treated with PPIs before or not? If he was treated with PPIs, then you start with steroids. If he's not treated with PPIs, you start them with PPI. Okay? So usually PPI, then you start with steroids. Because GERD can give you eosinophilia as well. That's why you start them with PPI. So the first line is PPI, the second line is steroids. If the patient was already taking PPI, then you start them with steroids. So that's eosinophilic esophagitis. So look for a patient with allergic condition, atopy, asthma, other things. The other thing, the last thing is caustic esophagitis. So those are the patients who drink Clorox to commit suicide. We see them very common in the hospital. So what things you do? The only thing you can do is you do endoscopy to see the regions, how severe are they. If they're mild, you can start them with liquid diet or soft diet. If they're severe, then you keep them MPO until they get better themselves, and then you start them with liquid diet. Things that you should never do in patients with caustic esophagitis or patients who drank acid or a base. Things that you should never do is induce emesis. You cannot give them things that they can induce emesis, okay? Because if you induced vomiting, that acidic or basic content would go back to the esophagus, cause more burning. So don't do that. They are at risk of perforation. So don't do that. The other things you should never do is you normalize the pH. So if a patient drank an acid, you don't give them a base to drink after the acid to normalize the pH in the esophagus, because acid and base, that will cause the thermophilic reaction, and that will burn the esophagus even more. So don't do that. Things that you can do is NG tube and to suction the things that the whatever they took, you can suction it, but that's only in patients who present acutely, or the patients who just drank like within few hours. But patients who drank like more than I don't have a specific number, but patients who are like they drank 4 or 5 hours, I don't think that would be beneficial. Sorry, I went too fast for esophagitis. So anything else you would like to ask me, or anything else you would like to add? Things that I maybe went fast, or things that are not clear?
No, doctor, that was good.
Okay, so to sum up, just a very quick summary. When you analyze a patient, or when you approach a patient with dysphagia, think of esophageal versus oropharyngeal. The things, the exam will be very clear, and the patients are very clear. If the patient has a problem in initiating swallowing, then that's oropharyngeal. If the patient has food getting stuck in the chest, that's esophageal. Then you look for functional or structural. Is it liquid only? I mean, solid and liquid together, or only solid? So if it's only solid, that's structural. Think of cancer, think of GERD, and think of the other things that we said. Functional, there are only 3 things: achalasia, scleroderma, diffuse esophageal spasm. So a patient, if a patient presented with features of scleroderma, that's a scleroderma related dysphagia. If a patient had sudden crushing chest pain, that's diffuse esophageal spasm. If a patient has a progressive problem of swallowing of liquids and solids, that's probably achalasia. One last thing to add in achalasia, I just remembered things that Chagas disease can cause achalasia. So if you saw a patient with achalasia, with myocarditis, thought of Chagas disease, then that's your diagnosis, okay? So that's basically dysphagia. Any questions?
No, doctor.
So from our discussants, Hamid, Mohammed, any questions for Dr. Abdullah or anything that you'd like to add?
No, it was very good. I don't have any questions.
Okay, from the floor? I'd just like to acknowledge Latifa Al-Kamali. She's been participating in the chat, and mashallah, she's been very active with you, Dr. Abdullah. So Latifa, thank you for that, and we hope that you had good experience.
Yeah,
so
thank
any
you,
more questions
Latifa.
from the floor?
Okay, if you don't have any questions, I can just say one thing. Please,
Okay,
whenever
Dr.
you
Abdullah, go
assess
ahead.
when you assess any chief complaint, try to, even when you see patients and take history, you can always go in and go back to the patient. So please go to the patient, ask the old cards, the template we have, then you go and sit yourself and you look for the differentials. Try to think of your differentials alone. Try to make a mind map of a differential for every diagnosis. Then you go again and ask the patient what are the things that rule in or rule out each one of them. And that's the way you learn, okay? So do that in every patient and you will be better than consultants, trust me. And that's it.
Better, doctor?
Yes, better than consultants.
Okay.
Okay, so if we don't have any questions from the floor, then I think we can conclude today's episode. So thank you so much, Dr. Abdullah, and thank you to our discussants. And we'll see you, inshallah, next episode.
Okay, thank you.
Thank you.